Boa noite a todos. Good night, my friends Nicos and Luis Leon. Very nice to have you guys here again. And first of all, thank you very much for all the support, the knowledge, everything you guys teach us and help us to improve our medical health system in Brazil, especially the vascular one. A lot of people are going to watch this live. We are recording and I'm going to send to YouTube, but we have almost 50% online now. So thank you very much again. This is aquecimento para o ScIENCE, aquecimento para o ScIENCE. We're just starting because we're going to be three weeks, we're going to be in ScIENCE meeting again. Nicos is going to come. Leon is going to do a live case from Tucson, and he's going to present one of his cases now. So thank you very much, Luis Leon. I think we can start. You can introduce yourself to everybody knows, almost everybody knows you, but some of them could not. So thank you very much.
I'll start, Igor.
Yes, you start, please.
Okay, so good afternoon, everyone. Good evening. I'm Luis Leon, a vascular surgeon working in Arizona. And Igor, beginning by thanking you as always for the invitation. It's always a pleasure to be part of this, the ScIENCE, and hopefully next year I can join you in person. Nicos, Arthur, Vitor, all friends for a long time now. Thank you for having me. So without further delay, I'm going to show you a recent case I did. In fact, I just finished the revascularization of this poor patient last week. And I'm going to show you, this is sort of one of the most complex cases that we have done here this is, bear in mind, this case was done in the outpatient setting. This gentleman is a 78-year-old male who has a lot of problems. He has diabetes, congestive heart failure, hypertension, hyperlipidemia. I met this gentleman 12 years ago. In 2010, and he has had multiple interventions in both legs because of critical ischemia. He has stents in the femoral popliteal segment. I also had to do a carotid endarterectomy because of a stroke a few years back. He is obese, and recently he fell and broke his right femur. And a colleague of mine did an iliofemoral endarterectomy because there was fear that the femur will not heal because of his disease in the common femoral artery. He also had coronary coronary interventions, only percutaneous. He never had an open bypass. So he still has veins in both legs. And he comes now with right second and third toe gangrene. So he went for an angiogram, and you can see here, the top is the right common femoral artery, and you can see how it's dilated. It's because the patient had a recent endarterectomy. His SFA is completely occluded, and the profunda is diseased, but it's open. And in a closer view, you can see that the patient has stents that almost go all the way up to the common femoral. But in closer look, the stents, they're not only occluded, but they are fractured in multiple places. You see that in magnification. Hopefully you can see clear that the stent is broken in several pieces. Like in that instance. So,
Luis, very quickly, yes. Is it fair to say that the overlap between the stents is far from ideal here?
No, Nicos, this is broken.
There's just only broken. The whole piece is a stent.
The whole thing is one stent, correct?
Wow.
Do you remember do you remember what the stent is that?
It wasn't placed by us, Igor, because I can tell you that we don't put laser cut stents too far from the profunda. This is just a laser cut stent from, I don't really care which it is. They're all suboptimal in my opinion.
I've seen several like this of cords, you know, the smart control. I don't use anymore. A lot of factors.
Smart, Absolute, Prodigy, all those, they break. And it's very interesting. This is the first point of discussion where you think that the artery in the thigh is static, that it doesn't move, but look, it does move. It torses, it bends, it elongates. So you can see how if an artery would not move, this would not happen. This artery is very dynamic, even in the thigh. So the misconception that the artery only moves behind the knee in the groin is wrong. The artery also moves within the thigh. And that's what causes this breakdown. So it's very important to have a stent that can be flexible so it won't break. So in comparison, you never see, I mean, there's been like 1 or 2 cases of superior stent fractures despite the thousands of stents that are placed worldwide. So that's what we really stay away from these stents and put interwoven stents like Supera in the SFA. So going back to the case, this case, I gotta tell you, I spent over 2 hours in the outpatient setting trying to cross these stents from above and below, and I couldn't. And it was too much discomfort for the patient. So I stopped and I brought him to the hospital to give him general anesthetic and try again. So what I did was I punctured, because I couldn't cross from above or below, you can see that I punctured the mid-thigh and I punctured the occluded stent. You see my hands there? And I just went through the thigh, to the skin in the thigh, and punctured the stent. And you can see once I'm in, I shot contrast to be sure I was inside the stent. And then I advanced a wire from the mid-thigh to the groin. And you can see right here, the wire is being advanced. Look how it moves the entire stent. And I can tell you that it was very difficult to cross the points where the stent is broken. It was very difficult to cross this point. It was very difficult to cross this point and this point. But with patients, we got all the way up. And you can see that now, once you are in the groin, the trick here is to put the wire in the lumen. And I couldn't do it. The wire will not go in the lumen very easily. So I had to resource to what's called the re-entry device or the Pioneer device, which is my preference. So here's the Pioneer device being advanced all the way to the groin. You guys are familiar with this device, correct? This is the device that fires a second needle. Yes. That is going to be fired into the lumen. So once again, I'm advancing the device right here, and you see two parts of the device, and the second one is the one that has the needle. Then I inject dye for further orientation, like in this case. Dye is injected, and then I'm gonna fire the needle guided by IVUS. So the image of the IVUS is right here. And you can see you have to put the lumen at 12 o'clock because that's where the needle is gonna fire. So I have the lumen very clearly here. You can see that the catheter, which is that X in the middle, is in the subintimal space, but the lumen is exactly at 12 o'clock. So I had my nurse holding the position of that catheter where I fire the needle. So once the needle is fired, then what happens is the wire goes into the lumen, and I'm cannulating the sheath that comes from the left groin. And right there is cannulated. So I'm gonna advance the wire all the way from the right groin to the left groin and convert the procedure again. I'm gonna show again, convert the procedure from retrograde, from the thigh, now to antegrade. So right there, the wire is going into the sheath. That sheath is a Terumo sheath, so I can uncap the top, and then we can go antegrade. So now, you see that we're in the distal part of the stent, but I still have to cross more SFA. That's the mid-thigh, that's open. And there's another stent distally, and you can see now that's a
Acabamos de perder o Leão. Deixa eu mandar para ele o link aqui de novo. Só um segundinho, pessoal. Já estou voltando aqui com o Leão. Já mandei uma mensagem aqui para ele, ele já está retornando. Será que ele conseguiu descer ali a femoral, hein? Vai ter que fazer um segundo varal agora, Manuel? O que você acha? Está mudo aí, mano. Aí, tô ouvindo agora. Tô ouvindo.
Ah, eu acho que se ele mostrou é porque ele conseguiu, né?
Eu tenho um spoiler lá, eu não posso falar. Eu e o Arthur, a gente viu.
E o guia já estava quase lá embaixo depois.
Caso difícil, né?
Muito legal ali em cima, né? Mas, então, nossa, em 2 lugares o stent, hein? Que stent que é? Ele falou qual era a marca?
Ele não sabe qual é. mas é um stent cortado com laser, né? Que ele não usa mais para femoral distal, assim.
Sim, sim, sim.
Smart Control, esses modelos, né? Ô, Nicos, será que ele não me respondeu aqui? Será que a gente continua com o nosso aqui, ou...
I can show my case, you know, to gain some time. And when Luis come back, we can go back to Luis.
Come back. Okay, let's go.
Let me just share the screen.
Vou tentar ligar para ele aqui, doutor Igor.
Tá, tenta aí, Arthur.
Okay, so hello everyone. This is a small preamble of what we're going to see in the main meeting. This is a complicated case with chronic venous disease and also outflow obstruction. It's a 36-year-old male with history of chronic venous disease and left lower limb DVT, presented to the clinic for evaluation of limb ulcers. Initially, he was diagnosed with varicose veins in 2003 as a part of workup for retroperitoneal lymph nodes found on the CAT scan. He was found with multiple varicosities and IVC segmental aplasia. Right, so let's think now. Young person, 36, IVC segmental aplasia, early DVT. This characteristic of young people, right, presenting with DVT when they have segmental aplasia or hypoplasia of the cava. Vascular surgery was consulted at the time, but the patient never followed up. He had developed bilateral leg ulcers on and off since 2003. He presented to our clinic for evaluation of the right lower limb open ulcers. He denies any fever, chills. He does experience bilateral leg pain, tenderness, heaviness, and fatigue. And his symptoms worsen with prolonged standing and walking up the stairs. So this patient basically has ulceration and a venous claudication. So it's severe, you know, post-thrombotic disease. If you look at his history, he's obese with lower extremity on the left side DVT, former smoker, family history negative for chronic venous disease, no allergies, and medication only aspirin. Physical examination, abdomen is soft with prominent lateral quadral varicose veins. Now having varicose veins in the abdomen, so indicates proximal obstruction. Okay? Both lower limbs were warm and well perfused, distal pulses. Prominent right lower limb varicose veins, 4 to 6 millimeters in medial thigh and calf, and 2 open ulcers of less than 2 centimeters with edema and hyperpigmentation. And to see a better, you know, image of the patient, these are the varicose veins that they extend, right, in the subcutaneous lateral abdominal space. And here you see the healed ulcer on the left leg and the big, you know, edematous calf and thigh with the 2 small ulcers, right? And also typical characteristic of chronic venous disease. Now, when the disease is so significant, and particularly when there is swelling in the thigh, we always think of iliofemoral disease or suprainguinal disease. And here we see the other side of the leg very nicely. You see the skin damage looks almost circumferential. We see some varicosities in the back as well. Now, if you look at the clinical severity, the right limb, which has the 2 ulcers, is classic symptomatic. Etiology is congenital and secondary because he was born with hypoplastic cava, or hypothetically, although it didn't have any, at the neonatal age, you have catheters going to your cava and you have, you know, aplasia. But this patient never had any catheterization. So you presume was maybe born with hypoplastic cava. And the left limb has class 5, which is a healed ulcer, symptomatic, and again, the similar part of disease. And both has sites of reflux and obstruction. And here, if you look, the ultrasound has chronic postrobotic luminal changes on the left common femoral vein because of the previous DVT, extending on the saphenofemoral junction, and also you see reflux as well. This is the femoral vein and the popliteal, and the patient has what we call axial reflux, right? From the groin to the popliteal veins. Also, the postrobotic changes are found in several levels. Here you see the saphenous vein on the left side is dilated, measuring 9 millimeters, but the saphenous has no reflux. That's very important because a dilated vein does not always have reflux, particularly chronic venous obstruction. So if you were to ablate a vein like that, then the patient is going to get worse. So this vein is an important collateral and does not need to have any ablation. See, the typical dilatation due to postrobotic obstruction. But varicosities, you see here, the texture of the skin has been damaged. You see this white tissue here is immense fibrosis, and these are varicose veins in the fibrotic tissue. That's why in this area we don't make incisions and phlebectomies, because you cannot get rid of these veins, and also you can cause an ulcer and infection. So these veins are treated best with ultrasound-guided foam sclerotherapy. And here you see on the right limb, although never had a known DVT, had an asymptomatic DVT, because you see the postrobotic, look at the wall thickening on the common femoral vein, and the femoral vein basically is practically occluded. And you see it continues all the way to the popliteal, and the popliteal vein has reflux. And here we see on the left limb the superficial veins. The veins are really big all the way. And on the right side, they have the same issue, but here we have like a small reflux. In people with postrobotic disease, people having like borderline reflux like this one, we don't touch the veins because for most part, this vein is bypassing the obstruction. But if the people having a dilated vein with a lot of reflux, then we treat the vein despite the obstruction. And here you see what would be the next step for this patient, right? You can do a venogram abdominal pelvis, do phlebectomies and ultrasound-guided sclerotherapy, perform the ablation of the SSV, proceed with GSV ablation, right? Basically here we need to know what's happening in the abdomen. It is nice to do a CT. And here you see on the CAT scan, the aorta, but there's no really IVC. It's all these multiple varicosities in the retroperitoneal space, right? And you can appreciate a little bit more here, the big varicosities on both, on the renal hilum and also in the area of on the right retroperitoneal area. Right? And you see the patient has an IVC higher up, but the infrarenal segment is actually missing. So what would be the best treatment option at this point? Una boot for ulcer healing, proceed with phlebectomies and ultrasound-guided sclerotherapy, proceed with the ablation of the proximal GSV phlebectomies, like yes or no SSG phlebectomies. Well, actually, for this patient, the best target now is to do compression for ulcer healing. Well, but it's nothing wrong if you want to, right, preemptively to do ultrasound-guided foam sclerotherapy. Because nowadays, we know you don't have to wait for the ulcer to heal with the compression to treat it. So what other imaging should we obtain? Venography, MR, CT venography, or repeat venous ultrasound. Ideally, because here the patient on the CAT scan has a problem, you should do venography with the intention to treat. In this particular patient, it doesn't mean you'll be able to treat, because if you don't find an axis to go through the vena cava, then basically you can't do much for the abdominal part. So to finish, in the interest of time, congenital anomalies of the inferior vena cava are present in 0.3 to 0.5 in young adults. In the general population, anomalies exist up to 8.7, but this includes aplasia, hypoplasia, left-sided cava, duplicated cava. As a matter of fact, I did not put it now here. We just published, or actually have a paper accepted, is in press in the European Journal of Vascular Surgery, right? Is in press right now and is available online. Agenesis of the vena cava usually occurs 6 to 2 weeks of gestation result from abnormal or regression during embryogenesis. However, this can happen because we put catheters during the neonatal age, and the IVC, the iliac veins, or both, right, they fail to develop. We know the IVC is composed of 4 segments: the intrahepatic, suprarenal, renal, and pharyngeal, and any of them or all of them can have hypoplasia or aplasia. This is important and can be explained because each segment arises from a different embryonic structure. The anomalies can be classified according to the segment involved, and IVC hypoplasia, as you said, may also develop after catheter use in neonatal age. This type of patient is easy to treat because even if the vein is thin as a spaghetti, most often you should be able to negotiate a wire and actually open the vein. You can do serial balloon dilatation to begin with, and then put, a stent. Patients with aplasia may remain asymptomatic as long as collateral circulation is adequate. However, if collateral blood flow is compromised or insufficient, venous stasis develops and progresses to DVT. Aplasia has been recognized as a risk factor for the development of femoral thrombosis in young adults with prevalence in about 5%. It's a beautiful paper retrospected by Demasmer, Marianne, who did a Benelux study. So they collect data in many years from Belgium, Luxembourg, and the Netherlands, and they found out that these people, at the age of 45 or less, they have, multiple episodes of femoral thrombosis and a very bad post-thrombotic syndrome. Why? Because they're getting DVTs and have severe compromised outflow. And with this, I will stop. This is the data I already told you. And maybe we can go to discuss a few things or go to Luis or whatever the time allows.
Ô, Nicos, vamos só falar alguma discussão relacionada a esse caso? O Vitor, o Dr. Walter, o Arthur, se alguém quiser falar. Mas eu tenho eu vou falar em português, mas eu falo em inglês.
Fala em
também.
português, por favor.
Tá, eu tenho uma dificuldade muito grande de tentar diferenciar uma agenesia, uma aplasia de veia cava, quando a gente faz o diagnóstico num adulto que tem um histórico de trombose prévio, sabe? Muitas vezes vem para a gente com diagnóstico já afirmado, eu tenho uma malformação da veia cava. Só que em muitos casos eu acho que é uma fibrose da cava retroperitoneal de uma trombose prévia, sabe? Você pensa assim, um ponto específico que você consegue diferenciar uma coisa ou outra, só pela história ou alguma imagem? O que você acha?
A história e a imagem está muito importante. Felizmente, durante o nosso congresso, em poucas semanas, o Dr. Kus Desai, de Northwestern University, tem uma experiência enorme. Nesses casos, quase todo no tempo, pode passar algum fio e abrir a veia.
Porque eu já consegui alguns casos muito legais, entendeu? Que muita gente fala, hipoplasia, a gente conseguiu. O Dr. Walter até acho que vai mostrar, né, Dr. Walter, um caso, né, que a gente vai até levar o paciente para você fazer ultrassom, Nicos. Você pode comentar, Dr. Walter?
Por favor.
Tá sem áudio, Dr. Walter. Tá sem áudio aqui. Tá estranho. Apareceu. Não foi você, Manuel, que falou?
Não fui eu que falei, mas é porque eu tenho uma pergunta.
Pode fazer, então, enquanto o Dr. Walter tenta resolver lá.
Nicos,
sim.
Digamos que eu identifique um paciente jovem que ainda não tem a hipertensão venosa crônica severa, ainda não desenvolveu dermatite ocre, ou de repente está começando a desenvolver e eu encontro uma agenesia de veia cava. E ele não teve eventos trombóticos, né? Sabendo que esses pacientes têm um risco muito alto de desenvolver trombose venosa ao longo da vida e isso agrava o quadro deles, a gente deve indicar anticoagulação para esses pacientes perene?
A verdade, ninguém sabe. Mas se ele tem qualquer episódio de trombose, eu penso que é a melhor coisa que poner com anticoagulação por a vida inteira. Porque eles têm seguro trombose, usualmente a trombose deles está iliofemoral. Mas se eles têm sintomas severos, no es necesario que esperar para detectar TPP. Puede hacer tratamiento inmediatamente.
Ok.
Ok, vamos voltar para o Luiz Leon, então?
Por favor.
Ô, Leon, vamos continuar.
Yeah, I'm here. I hope it shows.
Só colocar você como anfitrião, já tá. Só compartilhar aí, Leon.
Okay. Can you hear me?
Yes.
Okay. I'm gonna try to bring the screen again. Okay. I think I left it right here. Can you see the screen, Igor?
Yes.
Okay, so I'm gonna go back to where I left it. And I think so the advancement was down to the thigh, and you can see how there is a distal popliteal stent. This stent is of the superes type, so you can see how it bends following the popliteal curve and doesn't fracture. So we tried to advance through the popliteal stent, and it went all the way down to the popliteal artery, but the popliteal artery was occluded. You can see this angiogram in this location, and there was no popliteal. You can see that there's what's called a caput medusae. There's all these collaterals keeping his leg alive, but not a proper popliteal. So patient had an occlusion from the groin all the way down to the tibials. You can see right here another shot. It's just the wires will go into collaterals only and not into the popliteal. But when you see, then we try to go retrograde. So we puncture the posterior tibialis artery based on ultrasound. And you can see right there, there's an injection of the proximal post PT, and it's occluded above. And so the AT is occluded and the peroneal is occluded. Everything is occluded. So it's very difficult to get access retrograde. I kept going distal, and very luckily, I found a posterior tibialis artery patent at the foot. So then I decided to access this artery. And you can see the access with ultrasound guidance, and a wire is being advanced from the ankle all the way up to the knee, trying to cross the popliteal artery. The wire would not advance very easily, so I had to go with 1.5 millimeter and 2 millimeter balloons sequentially, trying to go and get to the popliteal area. And once I was in the popliteal area, look at the calcification of this popliteal artery. It's dramatic. I mean, it's one of the worst I've seen. And so we see, I have only 2 or 3 centimeters to cross, and it will not cross. The problem I have, I feel that a crosser device, I'm not sure if you're familiar with that device, but a crosser device from BD would have been a good option to cross this lesion interluminal, but we don't have it in the hospital. So at this point, I can tell you that I began this case at 3:25 in the afternoon, and I finished at 3:44. So it was 3 hours and 20 minutes of trying, and it was impossible. So I decided to stop. The patient had a vein map, and you can see that his vein is very good size-wise for a bypass. So that's what I decided to do, because there was a common femoral that was open and the PT was open in the foot. Patient went to have a open bypass. So I just have to show you, this case shows the application of multiple advanced endovascular techniques, but yet there's such a severe calcification of the popliteal artery that couldn't be crossed. A word on venous harvesting. In the past, we used to do long incisions to harvest the saphenous vein, but now this is what we do. We use endoscopic harvesting, where you put 3 small incisions, one in the groin, one by the knee, and one in the ankle, and we advance a scope. And this scope gives you this view, and you can see how the saphenous vein is clearly seen, and you can see every branch of the saphenous vein, so you can cauterize the branches and excise it without having any incisions, so very small incisions. And in fact, the incisions that we make to remove the vein, we use them ultimately for the bypass. So the patient has basically 2 incisions, one in the groin, one in the foot, for a bypass like this. So this patient has very few times I've seen, Nicos, how often do you see occlusion of the vein because of calcification intravenous, which is what this patient had? So the proximal anastomosis had to be revised and patched for us to do an open bypass. So this is the entire presentation. The patient is doing well. He has a palpable pulse, and I'm hoping he will heal his wound. So I'm sorry for the interruption. Nicos, I wanted to ask you that. How often do you see calcium blocking the lumen of veins?
That's not so common, Luis. I mean, we see it from time to time, but dense calcium on the venous thrombus is not so common.
Yeah.
Luis, really,
Yes.
really nice case. Thank you very much for presentation case that you don't have endovascular success because everybody wants to show only the good case. And this is really nice because you use several tips and tricks that most of people don't are used here, but like the IVUS Pioneer is a really nice trick to use. Retrograde approach, puncture the stents, wonderful case, and you, like a good surgeon, could solve the problem at the end. Really, really nice. Alguém tem alguma pergunta para ele?
Luis, in a patient like that, would you prepare to do a bypass? Would you, if was, I mean, did you tell the patient, listen, if this doesn't work, I'm going to do a bypass on you?
Yeah, so not in the same setting, Nicos. The first time, like you saw, is 3 hours and 20 minutes. If I would have added a bypass, that would have added another 3 to 4 hours. It would be too long. So I tell them recently, you know, these are the options. It's going to be, I told you already, Nicos, it's been 12 years of a relationship with him. Yes. His CHF is getting worse. His condition is deteriorating fast. So I really wanted to avoid an open bypass at all costs. I told him that an amputation may be coming soon his way. But in the end, we tried for 3.5 hours on Monday. And because we did not succeed, I booked him for surgery on Wednesday. So surgery just happened last Wednesday, and he's doing well. But yeah, the conversation is held. I rarely do the endovascular and the bypass at the same moment. And honestly, with all the tools that we have nowadays, it's very rare to fail an endovascular revascularization. Most cases can be open, but you saw this calcium. I mean, there was no way to tap up the artery. It was too occluded. So I figured I'm just going to stop and do the old-fashioned surgery.
Oh, Leon, cases like this, I've saw some publications and some case in LinkedIn of a group of Italy that they do arterialization of venous veins in the foot. They use the Pioneer to go the posterior tibial, then they go to the vein, they put a Viaband and open with cutting balloon, they open the veins in the foot. And then they make an arterialization. Have you done something like that? Do you have an idea if it's good or not?
The answer to your question is I have not done that personally. In my town, Dr. Scott Berman, one of my partners, has done one case, and Dr. Sabat, there have been 2 cases done in this town, and I think the results were not that great. Now, even in the best hands in Italy, this came all from Italy, and Dr. Miguel Montero in Houston at Methodist Hospital, he has done quite a bit of work in this technology, and even talking to him, the technology is not fully developed yet. There's no way to know who's going to do good, who's going to do bad. They're checking parameters, Nicos, maybe you can educate us on this, but there's acceleration time in the veins of the foot that they're checking, trying to predict who does good and who doesn't. But the technique is very sound, Igor. You know, you connect the artery to the vein through a stent, and then you break the valves. It makes sense. But the results are not as good as they thought. But I think it has to be improved more and more. In fact, we have a symposium this October here in Tucson, and Dr. Montero is going to come to present venous arterialization because I'm interested in learning more and more about that. Nicos, what is the acceleration time in the foot?
Luis, the acceleration time is basically it's not that useful, I must say. There is a group here in the States that published a few papers that shows there's a delay on the peak, and the delay on the peak basically shows low perfusion. However, for what we know already, does not have much clinical utility. Now, regarding about the arterialization, Luis, although the idea sounds good, nobody has figured out how the blood can go down to the microcirculation and go to the arterioles where it needs to be to feed the tissue. And in all honesty, I've not seen any good data. I mean, the technique is exciting, but there's not any good data anywhere.
Yes.
And believe me, Luis, this technique, it was not, new. It was done in Denmark in the 1980s in 5 patients, right? So, but with the open surgery. But I'm not saying we should not doing this. Like you said, we need to evaluate to see what's the potential, and if it works anything, and in which patient, basically.
Yeah, Nicos, I'm even aware of papers before because actually a surgeon from Peru, his name is Dr. Lengua, Lengua, and Dr. Lengua has done he spent some time in France in the 60s or 70s.
Wow.
And doing open bypasses. So he was connecting the saphenous vein to the artery and breaking the valves of the saphenous vein in the foot. So this technology is old, but like you said, this is not successful. They're still trying to get ways because, like Igor said, there's now endovascular ways to make these connections, but we are far from having a good technique.
Mm-hmm.
I think the best indication, I think, because I have no experience, would be that kind of patient that you don't have more arteries in the foot, you know, then you don't have outflow at all.
Yes.
So
this patient had a PT still.
Makes some sense. Yeah. This you have a PT.
But somebody else who has a blind foot, there's no arteries in the foot. That's what you do. Exactly.
Luis, can you quickly summarize the technical errors done on the case before you intervene?
Prior interventions, you mean?
Yes. When you look like a surgeon, you look like what was done in the patient. In your opinion, what was done wrong and should not be done?
I'm not sure, Nicos. I think the only thing I can criticize was the type of stents used. I think using these stents in a very mobile, dynamic artery, if you use laser cut stents, they're too rigid, they're not flexible, so they will break. And this is predictable. Every time I see a stent, you magnify the view and you see a fracture of the struts. It's always the same. And the problem is, you can think that it's just fracture, but it's very easy to cross. But when you think in 3 dimensions, there's so many wires intertwined to each other. The wires do not cross very easily. This case took forever, Nicos, to cross just the struts that were broken. And then to convert the case, it was a nightmare. So the type of stents, I think, and to say that something was done wrong, I would have to go back and see the indications as to why the patient had. But I gotta tell you, this patient has such a severe peripheral disease. His carotid was done, his coronaries, both his legs, yeah, you name it, CHF, and you know, and like I said, calcium in his veins. It was just crazy.
Ok. Alguma outra questão aí? Alguém que está assistindo quer falar alguma coisa? O Ítalo, o Alexandre. Se alguém tiver alguma pergunta aí, se tiver com vergonha, pode mandar no chat aqui, tá bom? So, we are going on. I'm going to present my case, okay? I'm going to present a case that I don't know if Leon and Nicos, they have this solution in the US, but it was my 3rd case that I used the solution, and I think it was a really nice case to present to show the options we had. So is a female patient, 85 years old, with mild abdominal discomfort, dyslipidemia, hypertension, a gastrectomy because of ulcer, and in the ultrasound they found a small aneurysm. But the angio CT, we see 2 aneurysms, one saccular and one fusiform. This is the run of the CT, occlusion of SMA, a saccular aneurysm, and a fusiform aneurysm. She had occlusion of SMA, stenosis of the celiac trunk, stenosis of the right renal artery, and a narrow aortic bifurcation. This is the measure we've done. So the left renal, there is a neck here to the abdominal aneurysm, but is in the same level of the saccular aneurysm. There is a 2 centimeter difference for each renal artery, occlusion of SMA, and stenosis of celiac trunk. The options we discussed here was do a chimney technique to the renals, a fenestration technique to the arteries. All this, we're gonna have some difficulties, and is a lady very old, 85 years old. We could just live like this, but the saccular aneurysm was significant, and she has some pain in the abdominal that we related to the aneurysm. There's a narrowing here in the aortic distal that would difficult ramificated, a branched, a fenestrate graft because of the size of the stent, the size of the arteries. So the solution we decide is to use the Altura stent graft. This stent is two separate stents that you can decide where to put according to each renal. Is nice that is very thin, so it's a 14 French axis. You can position each stent according to the ipsilateral renal artery. And we also do our arm access to check the sac, and if we have some complication with the celiac trunk and the renal. So this is the Altura system. You don't need to put them at the same level. You can make a difference. And the distal end, you can open from below to the proximal. So it's a nice, okay, is a nice device to use. So what we've done, we come from below, prepare for the aneurysm treatment. I just left a vert catheter inside the sac because I was afraid of not achieving complete occlusion of the proximal neck. So I could make an amble with coils. I have everything in the room to finish that if I couldn't succeed with my tactic. So I just left one of the stents close to one renal and the other stent close to the other renal. When they open, they stay like this. This is just to show you how they used to you can open. And the nice thing, the other thing, that you can flush inside the stent. So you have some steps before you release everything. So you can close again and reposition if you want. It gives precision. He opens a little. The last step, it moves a little, but you always can close again and reposition, and then you go testing to find the best place to place to deliver these stents, like this case. And you can shot from both stents. You know, you don't need a pig access, a pigtail from above. And then just to show how they release the free flow. So we finished the proximal, and then distal is nice because you open from distal to proximal. Is good because you have a lot of precision. Just to show you guys how you can open here, you can close and come back and go again. So it's a nice device. We're just starting to use, but it seems to be useful in some case. So this is the after the proximal ballooning. Everything is good. We have no flow here in the sac. My catheter is there, my vert, and I didn't use it to do anything. But the flow in the celiac trunk was very slow. And I was concerned about that because she had an SMA occlusion. So we went to check, and there is a tight occlusion of the celiac trunk, and I do a stenting. I use a palmas, and we could open, and it's good. I just checked the left renal because I was afraid of the stenosis, but the flow was good, and I decided to not put another stent. So this is the phago angel. Everything is good. Okay. Have you guys ever seen this stent graft before?
No,
Yeah,
impressive, Igor. Very nice. He offers a lot of solutions. If it works well, it'll be amazing.
It's nice.
I saw this stent before, Igor. This is there was a company named Lombard.
Lombard, yes.
That used to manufacture the Aor Fix device, which was that device that had like a fish mouth that you can rotate according to the position of the renals. And they were releasing the Altura graft in Europe. This happened like, I don't know, 8-10 years ago. and they were going to bring it to the States, but something happened. The company went bankrupt in the US, so they stopped selling devices here in the country. But I was going to
a Chinese company bought them. They're done in China right now.
Yeah, we don't have them. So I was going to ask you, do we have, what was the length between the lowest renal and the top of the sacral aneurysm? Because another option would be an ovation graft.
But there is no neck, because the left renal was the same level of the sacral. So or I do like this, or I had to do like at least a chimney,
I see.
And it's 85 years old lady, and I said, oh, I need to find a solution that is very fast, and I'm not gonna give a lot of problems to her, because this kind of patient, they don't support any complication, like celiac trunk, they close, they die, renal artery, they lose, it goes very bad, right? The only thing I think is we should be very concerned about using this, because the two free flows they are together, they're separate, but they close together. And if there is an enlargement of the proximal neck, I cannot find any solution to that.
Well, there's no solution, because that's the same problem with the Nelix device.
The Nelix, yes.
It's the same system of two parallel systems. So if you have a type 1 endoleak, you're lost.
You're lost. You don't have anything to do. That I think. But 85 years old lady, okay, and I just left the vert catheter, because I thought if there is one endoleak and I do coil and ambo and whatever, and I close that sacral,
Yeah, so one of my partners, Igor, has done here in Tucson 5 cases of elderly people like the patient you presented, who have type 1 endoleaks after endovascular repair. And what he has done, and I think it's a nice procedure, he does a small left retroperitoneal incision, and then exposes the neck of the aneurysm where the endograft is. And he puts stitches from the outside. So you don't need to cross-clamp the aorta. You just identify where the proximal end of the stent graft is, and you put stitches securing the graft to the wall. And, some patients did well, other patients die for unrelated reasons, but I think that's a good medium-sized technique. You don't have to cross-clamp the aorta, because that would be too much for this 85-year-old patient, but you can just put the stitches, and that will be a small retroperitoneal incision, and it will be an easy solution.
1 year ago, what I would do is use the in-craft system that is very thin also, because I don't know if I have in US, but here we have the in-craft is very, very small, and the bifurcation of the aorta is a problem. So I always decide a thinner one. I would like, if I don't have Altura right now, what I will do is to do a chimney for the left renal and bring the neck above. And after putting a regular device, I would fix with endo anchors, That's what I would do if I don't have the Altura system. Pessoal, alguma pergunta aí? Pode falar em português também, viu? Vitor, Chacon, Arthur.
Igor, as you mentioned in this person, the SMA was out anyway. So, you can do I would call a not so difficult fever. I'm not saying you should do this, but it's another option.
It's another option. I thought about this.
Ô, Igor, deixa eu te perguntar. Vocês ainda usam multilayer ou não? Como é que tá?
Não, acabou.
Como é que tá a prática? E os estudos de longo prazo todos mostraram que não valia a pena? Você tem essa informação, Nicos?
Não tem, não fizeram estudo direito, né, Nicos?
Foi como se você tivesse interrompido.
Acho que ninguém nunca topou fazer um estudo grande, prospectivo, randomizado. Então não tem, né, Nicos?
Exatamente.
Multilayer para aorta. Esses casos anedóticos.
Igor, tá ouvindo agora?
Tô ouvindo, Dr. Walter.
Então, hi, Nicos, how are you? Nice to see you.
Dr. Walter.
Hypoplasia of cava. Frequently, we have DVT in young patients. No, we had 2 patients with DVT with 17 years old. The older was 20 years old. And we treat the cava with stent, cava and iliac, kissing stent in the iliac and a stent in cava to reconstruct the cava with good results. We have a patient that will be in the ScIENCE to do the Doppler ultrasound.
Oh, bem,
and
que bom.
I followed this patient for since he's 32 years old, and he had DVT with 17, and he is fine. The stent, I think, he has 3 or 4 years ago. And the Luis Leon surgery, the bypass, I think it's better than the angioplasty in this case. The durability of this case will be better with the bypass. Don't you think?
Hi, Dr. Walter. I agree. I just that like I said, the patient is 12 years older than when I met him. So I've seen him getting older and older and weaker. He doesn't walk much. And so I didn't really want to do the bypass, but ultimately failed. And I ended up doing the bypass. And the bypass, it has a palpable pulse. I think it's going to last much longer. I agree with you. So maybe Nicos, going back, maybe that's a criticism. Maybe I shouldn't have put him through 7 hours of endovascular surgery. Maybe I should have done just the bypass early on. It's just a judgment call. And there was a question from somebody in the audience, surgeon named Alberto, and he's asking me if I would have considered going from the artery to the popliteal vein into the artery. I've never done it, number one. Number two, I imagine it can be done with a re-entry device, but I think before that, I would just do the bypass. If there's a target, I think the bypass avoids me that problem. But I've never done it, honestly.
The distal anastomosis was in the tibial posterior artery.
Yes, it was.
Yeah. It's a good final image.
Yes.
Você vê que legal o jeito que eles fazem um harvesting, né? Que eles tiram a veia. E aí, será que o Vitor falou isso? Será que os cirurgiões cardíacos têm usado essa técnica para tirar a safena aqui no Brasil? Vocês sabem disso, não?
O Igor, há uns 20 anos atrás, quando eu voltei para o HC, tinha um dispositivo que você ia fazendo um túnel e clipando as tributárias da safena. Eu acho que saiu do mercado, porque, não sei, ninguém mais quer operar. Mas existia isso aqui. E hoje eu estava numa cirurgia que o pessoal da cirurgia plástica, eu vi um dispositivo que eles têm um tipo de um laringoscópio que ilumina o subcutâneo para colocar prótese de mama. Eu achei legal esse dispositivo para fazer isso daí, de repente.
Pequenas incisões, né?
Pequenas incisões.
Vai com ligamento.
Walter,
Oi. Essa para retirar a safena, o pessoal da cardíaca, pelo menos ali no Sírio, eles estão usando a equipe
então
do Fábio. Do Gaioto.
Tá. Então existe, é que realmente saiu do mercado para a gente, mas para eles ainda tem.
É que a gente não faz também, né? Ano passado a gente fez um bypass. Tipo, é difícil, né?
Mas a gente tem que pensar no bypass, viu? Porque o bypass com certeza dura mais do que a angioplastia.
Vai convencer os pacientes, né?
Não, pô, eu tive bypass de 12 anos, poxa.
Não, com certeza, é excelente, excelente. É que, igual o Luiz Leão falou, com as tecnologias que a gente tem hoje, dificilmente você não consegue fazer endo, né? E aí, quando a endo dá errado, o bypass salva, né? Então, faz sentido, né?
Por isso que precisa saber operar, né?
Precisa saber operar, né?
Igor?
Ô, André, tudo bem?
Tudo bem.
Quer falar inglês ou português?
Não, falar em português. Aproveitando aí o multiler, eu gostaria de tirar uma dúvida com o Nicos. Nicos, tem um paciente que eu acompanho, ele foi operado aqui, não foi pela nossa equipe, e ele tem um aneurisma que pega os vasos viscerais, né, tronco celíaco, mesentérico superior e renais, e acaba logo após as renais. E colocaram um mutilê. Estou acompanhando, esse paciente não está tendo um crescimento significativo do aneurisma, mas eu fico na dúvida de como colocar no laudo a parte do fluxo fora do mutilê, né? Porque o mutilê é um stent não revestido. Então, a gente pode chamar de endolique isso aí ou não? Como é que a gente pode colocar, orientar no laudo isso aí?
É interessante porque esse tipo de injerto está bom se tem um aneurisma que pode preservar no flujo, mas esse é um pouco complicado, tem muitas artérias viscerais que estão envolvidas, né? E não sei como falar isso, porque não temos nenhuma evidência ou documento na bibliografia. Assim, não sei que está indo líquido ou não, mas uma coisa que está certa nesse paciente, se vamos ver como vai evoluir, né? Não sei se ele vai, aneurisma em futuro vai aumentar e crescer ou não.
Artérias pequenas, né? A neuro usa pra caramba e dá certo, né? O diversor.
Não,
agora, para artérias grandes que a gente não sabe, né? Seria um endolique tipo M, né? De multilayer, né, Nicos?
Sim.
Pois é.
Luis, for your case, when you do the discussion with the patient, what did you tell him about his life expectancy and the possibility of an amputation?
We had that discussion, Nicos, after my first endovascular failure. I told him that because he was very mobile and very weak, his frailty score is very high. I had a very serious discussion as to maybe an amputation would be the best way, because doing more and more limb salvage surgeries may end up in a heart attack. We had a discussion before. I think it would be appropriate because the patient has very limited mobility, very limited. Mm-hmm. And I told them that once you pass the emotional aspect of an amputation, maybe that's the best way to just get rid of the wounds, get rid of the pain, and be done. Because this patient has an ulcer in the left foot now, which I have to deal with. And so he has critical ischemia of both legs with a bad heart at 78 years old. And so I offered that to him, but he does not want to lose his leg. He wanted anything possible involving a bypass, despite the risk of a heart attack. That's what we did it. And Nicos, I faced these decisions from the patient standpoint through my father. My father was a surgeon with peripheral, and he'd rather die before losing an amputation, and he'd rather die on the table while trying a bypass, just like this patient. And his daughter is crying, and luckily he's done well. He went home today with an open wound, and I'm going to see him in a couple of weeks. So in July, I'll give you follow-up maybe about this patient and his wounds. But it's a difficult situation with bilateral critical ischemia, both legs occluded. Now he's looking into another bypass in the other legs. So it's...
No, Luis, that's perfect. Because to me, what you did is the correct thing. I mean, you carry the wish of the patient, which has to be respected. But I think, like you said, you have to put on the table the amputation, so kind of educate the patient, and the patient have a more educated decision.
Yeah.
Because you know what happens here, I mean, probably in Brazil too, but in the States, people do 1 million procedures where they know that they're going to amputate the leg. So they bill so many things to put money in their pocket or whatever, right? And then they do the amputation. I'm not saying this patient in particular, I speak in general.
Yes, yes.
Okay, my friends, any other question?
Tem aqui para o Leon.
Yes.
Leon, if you could have vascularization past the wire into the artery, each kind of the stent that you would to put in this case?
If you're talking about the proximal SFA, where those broken stents were, my plan was to cross, balloon, and put supera stents inside. That was my original plan. Supera or maybe cover stents like a Viabond. But because they were all fractured, ideally we have put superas. That was my initial plan. to re-stent the whole thing again with Superas, and then plastic and atherectomy of the tibial arteries. But I couldn't cover the tibial artery.
Leon, Andre is asking this, but in the popliteo, that highly calcification also. I had one case 2 weeks ago that I used at Supera, and I broke the calcium, and I put the stent. When I shot there was extravasation. No, I broke the artery, and then I had to put a Viaband inside, and it is done. The patient is good. But this is a problem, right? With a lot of calcification, because you have to prepare a lot the vessel. So sometimes it will broke, right?
Absolutely. And so we're start to use the what's the
shockwave.
Shockwave. Yeah. That's probably the best tool we have for severe calcium like this case. But you're right, Igor. If you don't prepare the vessel correctly,
and Supera, sometimes the Supera is so difficult to open. If he kink in a place, you were in trouble.
Absolutely.
It's terrible. And I never gonna pass through this again. And also I always prepare a lot before putting a Supera.
Yeah, so unlike other stents, when you put another stent and the stent is deformed, you can post-dilate and the stent's open. With Supera, that doesn't happen. With Supera, if you put it in and it's narrow, there's no way to post-dilate them. You have to do it beforehand. But the last thing I want to say, Igor, is that I spoke to the technologists in my hospital that do the laparoscopic vein harvesting, and they're going to present in your symposium in July. So,
nice.
They will show you cases. They've been working with us for years. And I was talking to Vitor about this. It makes sense in the heart. It's much easier because the heart surgeon is opening the sternum, and at the same time, they're harvesting the vein in the leg. So when the heart is open, the vein is ready. So it minimizes the cardiac surgery time. But for us, they're working in the leg where I have to go working on. So the usual how it works is they begin working, and then they call me, they say, we have the vein. So then I go and I open the arteries and do the anastomosis. So it's much simpler because, a bypass, if you do it yourself, you have to harvest the vein, do the proximal, the distal, the anastomosis. It's a long operation. Whereas now I go in and the vein is ready. And so I just open the proximal distal and it becomes less than 2 hours. So it's much nicer. But you'll hear details. You'll hear details in the July symposium.
Nice. Sorry, Igor. In our hospital here, one of our sisters, Winthrop, the cardiac surgeons, they do this technique for many, many years.
Yeah.
And in cardiac surgery, it makes a lot of sense. In vascular surgery, for the reasons you mentioned, but also if you look at the complications, you're gonna do a bypass, you're gonna have a big incision for doing distal anastomosis. And most of the infections, the problems happen in the proximal distal anastomosis. So I mean, maybe you save something, but not much as in cardiac surgery.
Yeah, but still, there's surgeons that do an incision from the groin to the foot, Nicos, to harvest the vein. You don't have to do more.
Oh, I agree.
Yeah.
You can to close everything. 2 hours just taking. Okay, Leon, let me ask you, tomorrow, if you can send me their names and cell phone and email and the title for me to put in the program and make it the formal invitation, okay? Thank you very much for all the support.
Sure.
Ok. E aí, pessoal, mais alguma pergunta para eles? Já estamos com 1 hora de live aqui e o pessoal precisa descansar também, né? Mais alguma consideração, Nicos? Leon? Alguém quer falar mais alguma coisa?
I think we are very excited to have the meeting in São Paulo. Very excited.
Reencontrar todos novamente, né? Vai ser muito legal.
Exatamente.
Muito legal.
Não todos.
Mas ano que vem você vem, com certeza. Vamos deixar marcado já. Next year you came. You're gonna come for sure.
He's training to run.
Now Brazil is gonna win the World Cup because Peru is no longer.
Peru is out.
Yes, Peru is out.
Peru is out. Okay, guys. Thank you very much. Have a nice night for everybody. Obrigado. Boa noite.
Bye, guys. Pessoal.
Bye.